Thank you very much, Parmida. Good evening. I'm Michelle Batty, and I'm the Programme Manager of the European reference network called EUROGEN, which deals with rare urogenital diseases and complex conditions. So all things which need highly specialised surgery. So just before we kick off, I'd like to take a couple of minutes to explain a little bit about what ERNs are and what we do. So EUROGEN is one of 24 ERNs created by the European Commission in 2017, and we're all aimed at improving care for patients with rare and complex diseases. And at the moment, EUROGEN is currently 56 healthcare providers in 20 member states. And really our aim is to deliver quicker specialist evaluation, more equitable access to high quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions. And they all need highly specialised surgery. So really where the expertise is rare. So some of our activities, I do hope you took note of the slides at the beginning. We have a special system called the Clinical Patient Management System, again kindly provided by the European Commission, which all ERNs use to conduct virtual cross-border consultations. So we can pull together multidisciplinary teams of surgeons and any other type of expert and provide advice on particularly tricky cases. So please feel free to get in touch with us via our website. This service is completely free for any healthcare professional working in a European Union country. We also work together on collaborating on clinical guidelines in collaboration with the scientific societies as far as possible. We conduct training and education activities. It's very exciting, we're developing a patient registry. So we hope over time we'll have the real world clinical evidence that's so needed for research, because of course you'll all know that the data is fragmented or lacking when we're talking about rare diseases. And then finally, we have produced this marvellous book, Rare and Complex Urology, which is the latest scientific knowledge collected by all our experts. It's available from Elsevier, so I do encourage you to buy a copy. So without further ado, this evening's webinar is on gynecological issues in patients with anorectal malformations, when and how to treat. And it's a joint presentation between EUROGEN and Anorectal, and it's kindly supported by both EUPSA and the Anorectal Malformations Network. And we're absolutely delighted we have an international flavour this evening because we have Professor Lesley Breech, who has kindly joined us. She's the director and lead gynecologist of the Division of Gynecology at Cincinnati Children's Hospital in Ohio, USA. And she also works as a professor at the University of Cincinnati College of Medicine. And she'll be joined by Dr. Alejandra Vilanova-Sánchez, who's a pediatric surgeon specialised in pediatric colorectal and pelvic reconstruction surgery at the Children's Hospital La Paz in Madrid, Spain. So tonight's webinar, it's well known that patients with anorectal malformations frequently have associated gynecological anomalies. And in this webinar, our experts will try to answer the most relevant clinical questions related to the medical and surgical treatment of these anomalies, especially in girls reaching puberty. And please note that the webinar is eligible for medical CME accreditation points for live attendees who complete the post-session survey within 2 weeks. So I'm delighted to give the floor to Lesley and Alejandra, and thank you both so much for joining us and sharing your expertise with us this evening. Thank you. You have the floor.
Thank you, Michelle, for this introduction. We don't have any conflict of interest. First of all, I would love to say that I feel very honored to have the opportunity to present this talk with Dr. Breech, who is one of the most experienced gynecologists in the world. on this topic. Today, we are going to present a review of the most common gynecological problems associated to patients with rectovestibular fistulas, with rectoperineal fistulas, and also to cloacas. We will discuss the options of different treatments, when is the best timing to treat and how. And also we are going to discuss the new consideration that has been taken into account, especially in the last couple of years, since we have more data available of the long-term follow-up of patients who underwent vaginal reconstruction some years ago. So we will complete this session with 2 clinical cases because Dr. Breech and myself wanted to transfer the theoretical concepts into real clinical scenarios. So please, Dr. Breech, you can start.
Thank you so much. I wanted to start with a quick thank you to ERN, of course, for the opportunity today, as well as the organizational team. And I want to thank Michelle for her great introduction, Parmida for the rest of the team for helping me in my technology skills to be able to see myself, hear myself, and hopefully continue to see the slides. It is a great honor. I think it's been my honor for many years to learn from many of the pediatric surgeons I've had the thrill to work with, ranging from Dr. Pena and Dr. Levitt to the pediatric surgeons who specialize in colorectal care here in Cincinnati. But it's just an honor for me as a gynecologist to have the opportunity to present. So thank you for the kind words, and I'm excited for us to begin our conversation this evening, or this afternoon for me, starting with some of those associated anatomic concerns. So on the next slide, for those of you who are already providing care to patients with anorectal malformations, may have some awareness of this already, but it is very important to take home assessing the reproductive anatomy in girls born with anorectal malformations. When I think of it, this is sort of our algorithm and plan for girls with a new diagnosis or that we're newly encountering with an anorectal malformation. I would say a complete genital exam. I have teased many times the pediatric surgeons that they're looking, you know, straight on to the rectum, and I'm like, no, we need to take a good look there between the labia as well, to document the anatomy, which I call the lower genital tract anatomy. So we'll have a differentiation on the subsequent slide about sort of the upper tract, the uterus, and the development of the fundus and part of the uterus, versus the lower genital tract, meaning the vagina, etc. So we would do a vaginoscopy, and I think that's something that has been discussed over many years about assessing the vaginal development, whether that's passing a Hagar dilator into the vagina itself. But I would advocate, when able, to be able to pass a small scope, such as the pediatric cystoscope, into the vagina and take a good look at that cervical and vaginal communication. Because in the end, for menses, the importance is that communication between the cervix and the vagina for adequate menstrual flow. In girls with anorectal malformations, we can see uterovaginal duplication, and we'll speak a little bit about that on the subsequent slide. So looking for that vaginal septum or duplication. Many years ago, before my hair started to get gray, we had done a project here at Cincinnati Children's, and those are the numbers you see from our review. But there have been a number of papers and publications suggesting similar percentages of uterovaginal anomalies that you see in girls with ARM. So even in rectal perineal fistula, there is a small increase over the rest of the female population in having uterovaginal anomalies. Rectovestibular fistula has a higher rate of that as well, and more commonly, uterovaginal duplication. And in cloaca patients, the vast majority of patients will have those concerns. I think that it wasn't until I was in practice myself that I had awareness of the known association of rectovestibular fistula with absent vagina, and it's important to keep that in mind. In our center, I know that we see a lot of referral patients, so we may have a little higher rate than what is seen in the rest of the population, but being aware and recognizing that association is very important. If we go to the next slide, is when we talk a little bit about patients that you may see perhaps later. As a baby, the child may have been treated perhaps in another institution, the family relocated, and you're entering their care a little later. You may say, gosh, there really isn't an indication at that moment to do an exam under anesthesia or a vaginoscopy. If there is, and there are other medical reasons for anesthetic, I applaud you and say, yes, let's go and check that out. If there are other surgeries that are indicated, as we go along, you may encounter someone who is coming to your center for bowel management. And if you're encountering a patient that might require daily enemas and they choose to use such as administration in an antegrade fashion, such as using a malone, that might be a great opportunity for your friendly gynecologist or yourself to document the reproductive anatomy. That's the internal genitalia, or thinking of the upper tract, such as do you see 2 uterine fundi? Do you see 1 uterus? Do you see that there are 2 round ligaments coming to the uterus, or are they separate? So that way we can get a good idea. I spoke recently in my own institution and advocated for photography or taking a quick video. So if you as the surgeon are in the abdomen for any other indication, it may be a great opportunity to take some photographs of that anatomy to document for the future, or even a short little video as well. But many times I will meet someone who has already had their definitive surgery and perhaps not had a good idea of what that anatomy is. And so we can use some of those other 3D imaging, 3D ultrasound. I have on the bottom of the slide an X-ray study that's showing a hysterosalpingogram, which is using an X-ray and some contrast for us to be able to see that that uterus is split in the midline, and you see that it's more very deep biconjugate uterus. When we have been in the abdomen for some of those studies, we have done a patency assessment, and we can talk a little bit about that. But on the previous slide, there had been a picture in the OR, and it showed how we were using a small pediatric feeding tube in the very distal end of the fimbria of the fallopian tube, putting this small tube, a little compression, and being able to test the patency of the reproductive tract. So again, being very gentle and careful with those fimbria and the fallopian tubes for the future, but is a technique that can be utilized both in an open case as well as in a minimally invasive procedures, which we're using more and more. So it's a good way of, again, making assessment, and that is of the patency. So if we go to the next slide, I think the importance for establishing the anatomy early on is to help us understand, is there any intervention or management strategies indicated? And when is the timing for that? Is that timing now as a small baby? Is it timing as a prepubertal girl? Or is it more important for us to address those things after we have the benefit of estrogen stimulation, which is coupled with puberty? Those longer term pubertal consequences can involve things like menstrual obstruction, pain, endometriosis. So it's very important for us to consider those, and at least by that time, have a good idea of a young woman's reproductive anatomy. There are considerations that could be catastrophic in some situations, but even for easy things like menstrual hygiene, a young woman may choose to want to use a tampon or a menstrual cup, and a vaginal septum and duplication may prohibit that. So there even may be straightforward reasons and less catastrophic reasons for us to understand our patient's anatomy. As an adult woman, there may be issues around the durability of the uterus, how well developed is the cervical region. Those consequences have implications in the future for carrying a pregnancy and those obstetric outcomes. So there's a lot to consider, and we're hoping that this evening we'll be able to talk a little bit about each of those aspects. I think that we had the GYN take-home points so that you leave with those starred things to understand. One of those is, what are those opportunities, as I mentioned, to assess the Mullerian anatomy or the uterus and fallopian tubes in the abdomen? Again, my surgeons probably get a bit annoyed with me, but we're always trying to take a good look and understand that. So any other abdominal procedure, the urologists are, when I'm there for urinary reconstruction, or when I'm there for a malone or for other indications to be there. We delineate the uterine anatomy, again, document that very well. We look for the risk of menstrual obstruction and thinking about the future obstetric potential. We even have within the chart little drawings that you see to the right, and using some of that terminology you'll see on the subsequent slide. We as GYNs don't always use the same terminology that the surgeons use, and sometimes can have some confusion. So I would urge you, this particular paper published in 2021 in Infertility and Sterility has about 2 pages of all of the different uterine anomalies that one could see. And so we have tried with our patients to be able to print that document, circle for them what we believe their anatomy is, so that they can use that moving forward to help their future providers be able to help understand their anatomy and then give them prognosis around obstetric management, but also be able to better understand their care. So I think this is something that many of us in the centers in the US are beginning to lean into. There's even a group that's working on a project around having a passport, so to speak, that has all that anatomy that patients can carry with them. After we have proof of concept, we'll be able to use that more on an app, because we know no one goes anywhere without their telephone anywhere anymore, but you could use that to share that information. So my emphasis is around understanding the anatomy at the earliest possible time, so that can prevent menstrual concerns, which we'll hit on today, but so also we understand obstetric prognosis. I'm sure that many of the families that you have met with will have hope for their child to have the ability to have a family and parent in the future, and understanding that can go a long way to help get through many of those other more acute concerns that maybe we understand more timely, i.e. the management of the colon and their urinary tract. So I think that we have coming up on the next slide the first case, and I think that these are cases that my surgery colleague either is putting me on the hot seat or us on the hot seat as a whole team on the webinar today about how we would manage the patient. So Alejandra, would you like to introduce the case?
Sure. Yes, so she's a 4-year-old female, status post PSARP for rectovestibular fistula, and she's visiting our clinic for the first time. Her parents reported that the gynecological system has never been evaluated before. On the physical examination, we can see a normal urethra. The anoplasty was located in the center of the sphincter after electrical stimulation. She presents a minor asymptomatic mucosal prolapse on the right side. And in vaginoscopy, we saw a complete longitudinal vaginal septum, as we can anticipate in the picture. So the first question would be, what would you do after this diagnosis of longitudinal vaginal septum? Option A would be wait until breast development to resect the septum, or resect the septum now, since the girl is already under sedation.
Yes, I am going to put up the poll question right now, so people can vote.
Mm-hmm.
I will give it a couple of seconds before I will show you the results.
I think this is an easy one. Then things are going to get more complicated. In the meantime, Dr. Breech, I would like to ask you, how do you resect vaginal septums? Do you use endocellular devices or electrocautery? How do you usually perform it?
Excellent question. I think that our team is probably similar to many others in using both of those opportunities. Younger patients, often it's a very thin septum, and we've used the electrocautery device. We have historically placed a few sutures to bring mucosa to mucosa, although there isn't really a good randomized trial to tell us if that's really necessary or not, but we have done that historically. In older patients, we have been using the energy devices, ranging from things like the Cool Seal to a ligature, etc. So numerous different devices. We do find those are very helpful, But as we get these answers, we can talk a little bit about timing, because I think that also influences accessibility. So
yes. And do you apply some estrogen cream after the procedure, or is not necessary?
right, great question as well. Again, we wish we had some randomized control trials to look at these kinds of things, but we have historically not administered any estrogen cream at that time. There, each time I go to present at different conferences, some of the teams say, oh, we give some estrogen ahead of time. Sometimes we apply some after, although they haven't well-established sort of data to help support how to do it, how much, how little, what's the dose, etc. And we have seen good healing without using that agent afterwards. So it looked like the majority of people were waiting, right? Was that what I saw the answer to be?
Yes, I think this, I agree with the poll. There is, we think there is no rush to perform the resection now, since we don't have to do anything with the anoplasty or any other additional surgical procedure in the perineum. And as Dr. Breech already said, in terms of healing, performing the resection of the septums once the estrogens are already present is a much better option, since there is less likelihood of adhesions and scarring. So yes, I would wait until she starts with some puberty signs.
I think that, again, the pendulum swing a little has also been sort of when the patient would like that, right? I think that sometimes I've met some girls who are on swim team or very interested in using some of those other menstrual hygiene products. There are some patients who say, I'm not even interested in that. I don't come in to have that removed, really. So I think it's very individualized. I think you had a great point, Alejandra. It was just around if other surgery is happening, sometimes that kind of pushes our hands slightly, but I would say generally we are leaning into waiting until later. As you can all see from that difficulty even seeing this septum there, it's hard to get in there and to do a surgery. I often say for us it's like operating through like a paper towel holder, right? Like the tube, you're operating through the tube. So, and I think there is maybe some question about what this could be associated with in the upper tract, correct?
Yes. So question number 2 would be, what's the most frequent associated uterine anomaly when we see a complete vaginal septum? The options are didelphys, classically called didelphys uterus, which means 2 different hemiuteri with 2 different cervices with 2 hemivaginas, septated uterus with bilateral obstructed endometrial cavities, or having this complete longitudinal septum doesn't mean that she will have any other uterine anomaly. What do you think? I already highlighted the right answer.
Yeah, I think she's trying to be tricky on that, though. I think, and I know that while others are filling it in, I noticed that you had not given us any information about what you saw at the upper part of the vagina during your scope at that time, and that would be a bit of a pitch. I know for this case we didn't want to say, so we didn't include that information, but I would encourage when doing that scope to document, you know, how many cervices you see, where are they positioned, is there a septum? So even if you don't intervene, you know, we have that information for later.
We saw 2 cervices, one each side to the septum. So we have 2 hemivaginas with a complete longitudinal septum and 2 different cervices. So.
Okay. And again, just trying to hedge slightly while we wait for that response from the participants before we sort of give too much information, but all that documentation can be extremely helpful. There are often questions from families for us around, you know, what we expect to see. So great. It does seem like most of the members of the webinar today had said that they think that this would be 2 hemiuteri with 2 cervices, which is definitely what we would expect to see more commonly in patients who present with that anatomy. The difference is, I think, even on here, there are so many on the ASRM description that sometimes it's actually hard to find the one that really is the patient's anatomy. But 2 different services would actually suggest actually a slightly better prognosis obstetrically for the patient in the future than if we saw a single cervix with a septated uterus. A septated uterus seems to have less obstetric capacity and may have an increased risk of first trimester losses. So actually for me as a GYN and OB sometimes, I think that seeing that adelphus uterus is more reassuring.
Okay, thank you. Yes, parents start to ask questions related to pregnancy and obstetrical outcomes right when the baby is born. And sometimes we have to get ahead and answer all these questions of the future. So we're going to go to the 3rd question. Would you perform an MRI or ultrasound or laparoscopy to confirm the anatomy of the internal genitalia at this age, at age 4? Yes, MRI or ultrasound starting now every 6 months, MRI or ultrasound after breast development and continue every 6 months. Or yes, MRI and laparoscopy now. So we need to take into account that we don't need to do any laparoscopy for any other surgical procedure. So what do you think?
So these are really great interactions because some questions come through as we go along. And I think one of the questions that had come through while we were talking was around, when we're going to do, if we're not going to do the vaginal septum resection now. It says, like, one of the questions was like, why not kind of waiting until the patient wants it? And I think that we agree that, I think we maybe are all saying the same thing, that waiting at least until puberty because of better healing, better access. And I think at that time, the patient can be involved in the decision making about timing for when they want to do that. Is that convenient for them? Do they understand what the risks and benefits are? And do they potentially want to have the vagina unified? So I think hopefully whoever asked that question will understand. I think that we agree that at least waiting until puberty so that we have that estrogen to help healing, but really when the patient and family with the family's input come to us asking for that.
Yes. So do we have
so it looks like yeah, it looks like it seems consistent with our recommendations, and we'll go over a little bit as we progress through the sort of menstrual part of things. But we looked at, would say, MRI or ultrasound looks like 75% of people say after breast development, every 6 months. I think we could talk a little bit as we progress through the discussion. In the slides we will present, the greatest risk of obstruction of the menstrual tract has been demonstrated in patients with cloaca. And if you are able to see 2 cervices, one on each side of that septum, it is highly likely that the patient will be at low risk for obstruction, so you might not need to repeat every 6 months. But I think the goal is to use that imaging to show us the upper part of the tract. Because typically, if you would just see one cervix, I would say we cannot 100% be assured that there is a normal upper tract. So I think it's almost like when you see 2 cervices, you're like, oh gosh, I have much more information. When you see one, there might still be a little bit of risk.
Yes, and I also brought up this question because sometimes I receive patients who underwent MRIs at age 2 or 3, and they couldn't see both ovaries, or they couldn't see the uterus, and that can cause a high level of parental stress. And there are many data available not recommending to perform radiological evaluation of the internal genitalia in such small girls, because sometimes we can misdiagnose something that is not really happening, right?
Correct. I think I can recall myself when I first started, wanting the baby or the small child to get the MRI so that we can square everything away. But honestly, without the pubertal stimulations, you can't see what I call the floor plan of the house of the uterus until puberty happens, and you can see more of the contour. So I would say I would agree waiting is most important. And so really breast development is the best outward sign that puberty is happening. I would say you have about 1.5 to 3 years from the start of breast development until the onset of menstrual period. So there is time to be able to make that assessment.
Okay.
So I think that was a great illustrative case to lead us right to the patency and the menstrual kinds of things. So the next slide talks a little bit about some of those factors that can influence the timing of the onset of periods. And so one of the things families ask me a little bit about is, are there genetic factors? Mom got her period at this age. This is the expectation for the patient. And of course, any delay in seeing the period could make anyone on this webinar nervous that is something obstructing. So I think keeping in mind genetic factors like mom got her period when she was 12 or 13, that is really still the sort of average age for patients to be getting that, a little bit over 12. But there are other influences. If a patient isn't showing external signs of puberty, i.e. normal levels of estrogen in their body, then they're still not going to have their period. So I think we need to consider those other aspects. We have not seen in reviewing patients with anorectal malformations any impairment in ovarian function. So we would not expect any delay in puberty. We would not expect anything other than normal estradiol and hormone levels. But what's most important is, as we've been talking about, how is the uterus developed? Is it completely developed? Is it patent? And how might we assess that? And what might be concerns and pique our interest about, oh no, could there be obstruction along the path? Any obstruction on the next slide could be associated with an obstruction to menstrual flow, and that would mean that you'd accumulate menstrual flow and blood superior to that or behind that, so to speak. And so it's really important to keep in mind the timing of when puberty started and the timing of when we'll see those periods. Patients often present first with cyclic pain if there's an obstruction, i.e. associated with each menstrual period. But you can imagine if you have duplication of those reproductive systems, one side might be flowing just fine. You'll be seeing menstrual periods come monthly, but yet the patient is still getting worsening pelvic pain on the opposite side. And those can be signs that there is an obstruction. Obstructions are not only painful, they cause enormous inflammation, and they can be associated with endometriosis. So there can be long-term effects to the patient who was obstructed for their eventual fertility. Sometimes the fallopian tube can be scarred so much that you'll develop not only a hematosalpinx, but long-term scarring to the tube and affect future fertility. So there are many consequences that have long-term effects from obstruction. On the next slide, we had what sort of started it all, so to speak. When I worked with Dr. Penny and Dr. Levitt in the past, they had come fresh off this paper and were very concerned about how we might make those assessments. This was a review at that time of patients with cloaca. Again, those patients who are expected to have more Mullerian anomalies than others, and those with complex anatomy. And when they reviewed those patients, about 1/3 of the patients had normal menstruation. 6 of the patients had had no onset of their periods, and these were all patients who were older than 14 years of age. But of those patients, about 41% of the patients had pelvic fluid collections. They had developed obstruction, and in those patients, 2/3 of them had sort of a difference in the way each side was developed. One may have been well developed and the other quite rudimentary. Of those as well, 4 out of the 9 also had some impairment in the vaginal development. So thinking back to the beginning of our conversation, this is why we want you to assess the lower tract, the outflow pouch, the vagina itself, as well as what's going on the upper tract. And that connection, the cervical-vaginal connection, is extremely important. So recognizing that early, well before puberty, gives us sort of a plan and a time to reconnect. I'm quite certain that in Europe, you can follow your patients long-term and not worry about them moving halfway across, the United States for us. And so you can make a plan about follow-up. This paper talked a lot about the proposed management strategy for how to avoid outflow obstruction more long-term. And then when it does happen, how to really make an assessment about managing that. And there are a number of different categories that we look at when we are assessing that. And some of those are around the patient's readiness. Sometimes that's about the patient's anatomy. Sometimes it's about the patient's pubertal development. So this table that's contained in that paper, which is a great reference, is something that really outlines a plan that you can have for managing an obstruction. We'll talk in a few slides about medical management, but what I would say is there are ways to turn something that seems like an emergency at that moment into something that can be treated, calmed down, and be managed in a more elective pace that may be better suited for a better outcome for the patient. On the left of this slide is just showing you how we often use an MRI, and we use MRI as our preferred imaging in patients with complex anatomy when we believe there's an obstruction. This just shows how we use actually a vitamin E capsule down at the place where the vagina should open. And so we allow that because it shows on the fat-sat images or the fat-saturated images on the MRI that we can see the distance from the level of obstruction or the accumulation of menstrual blood to the skin to help us see how challenging or difficult the surgery may be. On the next slide, thank you, right? This was what the management strategy we had developed here at Cincinnati Children's when we had a patient with cloaca. Obviously, as we mentioned, we'd sort of delineate that anatomy as much as we could as an infant or during the definitive management. And then when breast development started, we would continue ultrasound on a cyclic basis because many of those girls are getting renal bladder ultrasounds and kind of follow until the patient became menarchal. So we would say we would continue another ultrasound after menarche to make sure everything drained. So that's probably about 1.5 to 2 years of some intermittent ultrasounds. And if we detected obstruction, we would progress on to MRI, and that would give us a little bit more information that you'll see on the next slide. The information the MRI can help us with is sort of that anatomy that's internal and that distance that we would have or what we need to approach. Sometimes that's a uterine structure with no cervix that may not be retained. We can talk a little bit about that on our next case as well. But I think if there may be structures that just need to be removed, but there may be others that we can preserve and connect, keeping in mind the risks and benefits of keeping those structures. If patients are in significant amount of pain, my experience in life has told me patients go from a small amount of cyclic pain to suddenly writhing in acute daily pain that just doesn't go away. And so we can use some medications. As I mentioned before we started with our colleagues, we often use medicines like puberty blockers in more aggressive situations where we might give injections of GnRH agonists. We have sometimes used an implant that we can place under the skin or sometimes some daily hormone so that we can reduce inflammation, delineate the anatomy best and understand what our next steps are, and then fit that into the patient's life, right? I think many patients might be involved in sports, might be in school, and this tends to happen at the exact wrong moment. Next slide. That hormonal suppression is a number of medications. I think my main message with this slide is to give it to you as a reference, but to partner with your gynecologist in your institution. I've been lucky enough to partner with fabulous pediatric surgeons, and I'm hoping that you have some fabulous GYNs to partner with to help with that hormonal suppression. We have been very aggressive about acutely using interventional radiology to drain a vagina or an uterine structure that might be obstructed. That has provided great symptom relief for the patient and allowed us to institute suppression to give more time to decide what is the next step. We use the MRI, as I mentioned, it's preferred, and we don't use contrast. And on the right at the bottom of the screen, I think you can see my little vitamin E capsule that you can see way down in the bottom right image, where you can see right there where the vagina would be opening, and you see in the image there a quite obstructed system that is not draining menstrual fluid for sure. I keep that hormonal suppression going through the definitive surgery that we may need to correct the obstruction. I want the patient to be safe. I want to be able to check how things have healed, so we keep that hormonal suppression going that whole time, and that's where that partnership more long-term can be helpful. I know, Alejandra, you are in a wonderful group. I didn't know if this is something that you see that frequently as well, or we want to wait and sort of hit on it on our last case, because I think we're going to shift gears into talking a little bit about the infamous vajayjay or vaginal grafts coming up. So we'll pivot slightly and just kind of touch on things that we think are changing in the management of patients with more complex anorectal malformations. Next slide has some of the tissue that we've used in vaginal reconstruction depicted in several drawings. Having had the fortunate opportunity to be in the field for over 20 years now, we have done many different types of vaginal reconstruction, ranging from a segment of the small bowel to a segment of the rectum that you see on the left side of the screen, to sigmoid, which is much more commonly utilized. But now in older patients, you can see in the center of the slide, we have explored other types of grafts, and those are things that are used for patients with less complex anomalies called buccal grafts, or you may have used in other situations. Next slide would be great. I think what the biggest discussion is around is what are the advantages or disadvantages of really aggressive vaginal reconstruction as an infant. I think many on this webinar may be close to my age, and in my training it was more about things, let's minimize the number of surgeries that a child needs, let's get everything done on the big surgery. I can remember my mentors would say on the surgical consent, we're just going to fix the baby. It wasn't what each part was going to be, because our goal was to do all that surgery at once. I'm not sure that the literature and the outcomes for patients would support that we are helping them as much as we thought. It has been the historical experience. I think many here know that there is some things we don't have data about, and you do what your mentor did. You did as you were taught, and we did everything at once. I'm sure many of you would appreciate that surgery is beautiful and wonderful in a small baby and small child who has not yet been able to have the opportunity to maybe gain some weight or grow so much that they have to be in lithotomy and in stirrups, and you might get a nerve injury from a long surgery where you're repairing a vagina. So there are some things that make it technically more challenging when you're not operating on an infant or small child. But some of the disadvantages of us doing it all at once might be some about suboptimal graft tissue. Those drawings I showed you in the short term can have some healing concerns. Sometimes we've seen that things don't heal as well. There's dehiscence at the wound site, particularly that pesky perineal body of any of you who have done those kinds of surgery, just any movement of a child, and that's going to break down. Some graft concerns in the medium term instead of short term or long term. Sometimes we've had patients develop colitis, have developed persistent discharge and frustration around those things. And then more long term, I think the idea is obstetric and sexual issues. We have patients who have begun to have those inflammation and colitis issues when they become sexually active. In addition to the idea of, can you deliver through that? And having a colonic graft in the vagina would right away say you haven't had an operative delivery. The need for additional surgeries due to prolapse or stenosis. And again, we mentioned how the operating on an adolescent who's larger and potentially has more technical concerns. On the next slide, I mentioned a few of the things that I have found, and the other authors have also found as disadvantages of using the bowel neovaginal grafts, which would be related to things like how well that graft grows and would be adequate for obviously what we need a vagina for, sexual intimacy, etc. Vaginal prolapse. I think that there have been many patients who were done as a small child, had vaginal prolapse repaired 4, 5, and 6 times, and now have stenosis and an inadequate opening to the vagina to use that again for intimacy. We've had a flurry here in our center recently of colitis. Several ulcerative colitis patients, and seems interesting to me because, again, having done the field a long time, it's a a larger number than we had seen historically, and I'm not sure if it's because we're getting to that larger group of patients who had had a colonic graft in place, as opposed to that being something that hadn't been around as much in the past. And then lastly, daily mucus production can be frustrating, but the significant and potential life-changing risk for malignancy. On the next slide, I just gave you some information on our patients. We had a review some years ago, and we looked at about 130 patients that had had vaginal replacement with the tissue you see there, rectum, small bowel, sigmoid. On the next slide was just really the emphasis that I would show you on the first line of the table. Really, the patients who had a rectal neovaginal graft suffered from lots of mucus, and that was a concern. I'm sure many of you would not want to use rectum because you want to preserve the bowel function for the patient, but in unique circumstances that has been used and is associated with more mucus. I think on the small bowel line, I would emphasize the first, which is more stenosis we found in those small bowel patients. Sigmoid seemed to be the sweet spot of the different grafts we had given, and then more prolapse, about 20% of patients in the segment that had received a segment of colon. On the next slide is just a summary of at least some information we had about that malignancy risk. There were about 23 reported cases of neovaginal malignancy in this paper. The majority of those were squamous cell carcinomas, but because many of the patients had had a skin graft, and we would expect to see that. In addition, HPV-related vaginal carcinoma is often squamous cell carcinoma, so that it can be associated with HPV as well. The 6 cases of adenocarcinoma are at the bottom of the slide, and of those cases, the majority of those cases, 4 out of the 6, had a case of getting a segment of bowel. 2 were sigmoid, 1 was colon, and 1 was ileum. So I think the concern is there some more risk to patients, more long-term, and when does that risk happen? On the next slide, my hypothesis is that the cancer risk develops over time with chronic inflammation. Chronic inflammation may be from colitis, chronic inflammation likely from sexual intimacy. The mean time to development was 19 to 24 years, and that suggests if you replace that segment of vagina when they were 1 year old, they might be using it for sexual intimacy in their 20s. So there is this sort of controversy about how do we follow patients and what should we do to look for that. Some authors had recommended beginning a regular surveillance program 10 years after reconstruction. I listed there what ACOG and others had said, but really it's unclear about how we follow those patients. I will say that we have pivoted and used some more tissue that we thought might be preferable in older patients, which I have on the next slide. And that's using buccal graft, as I had said. Maybe it's more similar to the true vaginal tissue. It's fairly easily accessible and not scarring with a more cosmetic result. Some disadvantages may be that we have historically only done that in older patients and not younger patients, and the need to be in hospital at sort of minimal activity for several days to a week. So there is some opportunity for us to pivot and innovate in the care that we're giving patients. On the next slide, there may be some alternative strategies to think about along that path of caring for those complex patients. Maybe waiting for vaginal reconstruction until other needs happen when the patient is older. And then deciding sort of how we will navigate through that puberty and sort of menstrual risk, looking at when puberty starts, what imaging we will use. Will we need to suppress the menses? Do we want to suppress that naturally and then use a more controlled growth? I've added back estrogen while I've had someone suppressed to get to a very minor obstruction, not painful, but stretching the vagina nicely. So that partnership with your gynecology colleagues may give some better outcomes for some of our patients in the future. So on the last slide, I just sort of proposed maybe there's some innovation for us on the vajayjay. We could readdress the timing. Do we need to do the vagina when you're an infant? Maybe it's better for us to wait for better options and to hear the patient's view about what they desire. Thinking about other tissue, buccal graft, or I think that there'll be a great opportunity for all of us to interact. We're reviewing all of our patients again in our institution with their bowel grafts currently. We're encouraging the multi-center group in the US to do that with us as well. And there are some new tissue engineering opportunities that are available for patients as well. And then I think all of you on this call are probably doing much more minimally invasive surgery. You're doing robotics, you're doing laparoscopy. That may give us sort of better dissection, may allow us to mobilize a natural vagina even better without doing as much disruption and scarring as it would be in the past. So lots of innovation and an opportunity for all of us to work together to better care for our patients. So I think we have a few take-home messages before our case, because I know we'll be ending up here very soon. Again, delineating the reproductive anatomy as soon as you can. Trying to make sure that tract is going to flow just fine by the time the first period comes. And then thinking about with your team really the timing of that vaginal reconstruction, because we can really be innovative in what is the graft we're using, the technique we're using, and the timing that we're doing the surgery. So I think the next slide is our final case to make sure everyone hasn't fallen asleep this evening or gone out for dinner.
Thank you, Dr. Breech. I'm going to present the second and last clinical case. This one is a little bit more complex than the previous one. I wanted to bring this particular case to highlight the importance of having a multidisciplinary team with gynecologists with treating patients with cloacas. This is a patient I met for the first time several years ago. She was then 14 after a PISAR boob for a 4 centimeters common channel cloaca. She underwent at outside hospital vaginoplasty with sigmoid at the time of definitive repair at 6 months of age. She had abdominal cyclical pain for the last 5 months with no menarche reported, and she was dry with CIC and clean with daily enemas. This is the in the physical examination. She was standard 5. She had a palpable mass in the right lower abdomen. The genital inspection revealed a patent and normal size introitus. The graft measured 10 to 15 centimeters of length, but no cervix was identified in the vaginoscopy at the top of the vagina. The MRI, as you can see in the lower right side of the image, an obstructed hemiuterus in the right side with hydrohematosalpinx and an atretic hemiuterus on the left side. We were not able to see any connection between the obstructed structure, the hemiuterus, and the vaginal interposition, but they were close. So why, this is the first question, and I wanted to ask you this question because I wonder why the surgeon did not connect the uterus to the vaginal graft. And option 1 is because at 6 months the uterus looked very small and they thought that it was atretic, both of them, and they did not have, it would have a endometrium, functional endometrium in the future, or because they are not experienced surgeons. What do you think? There is any other option?
Right, are there any other options, right? Because I do think I would say it is hard to assess the reproductive structures at age. I think there's a great paper that came from Nationwide and my respected colleagues, Dr. Hewitt, about really how do we tell how well developed that structure is. And I think often the error would be to keep tissue to preserve fertility potential rather than to remove tissue, right, that may not be clearly underdeveloped. So I think it's hard at that time. Yes. I'm thinking it's not because they're not experienced, but they were probably thinking it was a little atretic.
Yes, that was my guess at that point. So question number 2, what would you have done differently?
Oh, sorry, Alejandra. I'm just going to share the results of what the attendees had voted on your first question.
Fabulous. Yes. We agree. They agree with us.
They agree with us? Okay, because it was not an easy one. Question 2, what would you have done differently in the past when doing the definitive reconstruction of this long common channel cloaca? Would you have connected the two hemiuterus to the graft? Would you wait until puberty to decide whether to perform an vaginal replacement or not? I think at that point, at least we are questioning these things, wondering if we have been doing the right things for all these girls for these past 2 decades. I don't think there is a right answer, in my opinion. I don't know what the audience say. I'm curious.
Well, here it comes.
Oh, I love it. It's very exciting, right? I think that as long as there's a surveillance program, right, to eliminate the patient coming as you have experienced this patient, right, you know, in so much pain, but I think would allow more options. The upper part of the vagina may have grown, you know, enough to not maybe need so much of a graft, or maybe there's different tissue like buccal graft that could be used, or tissue engineered tissue. But we have a couple of girls with cloaca that have about a 5 centimeter common channel where we have actually closed the vagina and closed the skin at the perineum, which gave me like chest pains because we had never done that. But I think it is maybe feeling like, at least for now, a good alternative in some situations.
Yeah, I think we need to select the patients. We need to trust families to make sure they are going to follow them up and they're going to come frequently to the hospital. So I'm not sure if we can decide to wait in all patients, because it depends on the setting. But I agree. I think we have been performing so many vaginal replacements, and now we see that not all of them are doing great. So last question, what would you do now? Because she doesn't have a cervix. So would you try to connect the obstructed uterus to the vaginal graft, or would you remove both hemiuterus, since none of them has cervix and one of them has not functional endometrium? What does the audience say?
I had to adjust answers a bit because there were a limited amount of characters that I could use, but I hope they get it.
Okay.
I think it looks great.
Thanks.
This is the most sort of interesting one, right? Because I think this is, I think there may be some difference European view versus in the US, because I think there is a risk aversion sort of component to the US view. So I'm very interested to see the answers by the participants.
That's why I wanted to bring that up. Because
yes, I'm very excited to see before I again throw any intel out there. I'm interested to see the result. Oh, okay. So connect the obstructed uterus and then remove the atretic. Yes, I think that's like so fabulous. I think here in US for sure, there have been a couple of older publications, but if there isn't a wonderfully developed cervix, even on the obstructed one, there's hesitation to connect those. Obviously, the one without any endometrium isn't really risk and no benefit. You can't really carry a pregnancy with no endometrium. So that obstructed one, again, depending on how much cervix, but sometimes it's hard to tell cervical development when it's obstructed, right? When you have this huge balloon blown up, sometimes it's hard to tell, and often very well developed. So I love the idea, as long as patient and family are aware of the risks and benefits and the idea that it may need future work. I love the participants in the webinar. They're right down our lane.
Yes, option A is what our gynecologists decided to do at that time, a tracheotomy and anastomosis between the vaginal graft and the uterus. She's now 17. She's menstruating regularly. But Dr. Breech, what are the real possibilities of a normal pregnancy with no cervix and the risk of ascendant infection with no cervix between the vaginal graft and the uterus?
All right. Excellent question. I think that it's a little harder to answer, and again, I'm always verbose, so I'll try to be short. In women who have had cervical cancer and had a tracheolectomy procedure performed, they have actually carried pregnancies with children. I think all is better than expected, but that is a normally developed uterus and cervix that then underwent resection of the majority of the cervical tissue. This is a different scenario, and so it is very dependent on how well developed any tissue was there, because there's a very high risk of ascending infection, and particularly not seen often until sexually active, because the transmission of the bacteria to the cervical region increases substantially at the time of sexual intimacy. And so we have seen patients who seemingly did just fine, but then began having recurrent tubal ovarian abscesses after the onset of sexual activity. So I think it's still out a bit on that. I would probably, like your gynecology team did, make that assessment, close follow-up with the patient, and hopefully understand those risks.
Thank you.
Great, thank you. We had a couple of questions that came in. I've already passed them through to you. Oh yeah, I can see that you have a take-home message if you do that. And afterwards,
We just wanted to
last slide, I promise.
I'm so sorry. You continue.
Thank you very much for this interesting discussion. To finish with our presentation, I would like to point out 4 aspects that, in my opinion, are very relevant for pediatric surgeons. I reckon that training in pediatric gynecology during pediatric surgery residency or fellowship is very weak. And I think all pediatric surgeons should have basic knowledge on anatomy and physiology and how to treat and prevent at least menstrual outflow obstruction. And I mention this particular condition because it has major impact on future reproductive and sexual life of these girls. Third, every pediatric surgeon treating colorectal malformations and rectal malformations, especially cloacas, must involve pediatric gynecologists. If you don't have available gynecologists with expertise on this type of malformations, you may need to transfer these patients with a center with the possibility of gynecological care and also transitional care. And last but not least, I encourage all pediatric surgery trainees to go to pediatric gynecology conferences. For me, going to these conferences made me bond with this special group of welcoming professionals, and I have learned a lot from them. So thank you very much, and we are going to take all the questions. Thank you.
Wow, looks like there's many questions.
I can see the questions. Can you see the questions?
It's a great question. It says, do you agree about a staged repair of a cloaca, or perhaps you just separate the rectum initially and leave the urogenital sinus untouched for later reconstruction? If so, what approach would you do to repair the urogenital sinus at adolescence? And I think my GYN comment will just be brief, which is it is an option. The advantage is if there would be no risk for menstrual obstruction.
Yes,
so
but
those,
we need a pediatric urologist to help us to answer that question, I think.
Agree. I think, again, there are those issues about reconstruction later, but it would tell you also more about the urologic behavior, right? You would know more about emptying, etc. However, in a patient with a long common channel like that, sometimes they don't empty well. And if they needed to pass a catheter, that can be challenging as well, right? If there's a long common channel that's not repaired until later. So I think there is a spectrum, and there may be times when staging that may be helpful. And again, I think this is a time of innovation, right? I think it's a time when we're looking at what are the best options for management. There is a case 2 why were not those hemiuteri were not removed at the time of the definitive surgery for case 2? And my only response for that, and I'll listen to you, Alejandra, is those, if we would have removed both of those then, you would have removed one that would never have been a problem, the left side. However, the surgeon would have been responsible for the patient's inability to carry a pregnancy in the future, because that one that's on the right side is functioning and is capable of making menses and potentially capable of carrying a pregnancy. So I think that that's the risk. If you remove both of them, then it may have been that surgery that made the patient not be able to carry a pregnancy in the future, not their anatomic condition.
Yes, definitely.
I was trying to scroll through, tell me if I'm going through case 2. It is a high common channel, 4 centimeters. Stricture at the anastomosis is a potential complication in those cases. Totally agree.
Totally agree. That was the other possibility, that they performed an anastomosis between one of the hemiuterus and the vaginal graft, but the structures are so tiny that maybe there was an anastomosis, but not anymore because it's scarred down. I mean, totally agreed. Could be any other possibility to not have a connection between the uterus and the vagina.
It is true, and I think sometimes we, we all need to think very respectfully of our surgical colleagues, that they probably attempted something like that, and instead of just sort of looking away and not seeing those, right? But they can be tiny, and that anastomosis may have been fabulous on the day, but they can stricture for sure.
Mm-hmm.
And I think the last question I saw, because I think we've run a bit over time, was about why do we need to keep repeating ultrasounds all the time for patients? And I'm thinking they're meaning during that time. I'm only recommending that during the time from when breast development and puberty starts until we have safely gotten through the onset of menarche and know that obstruction has not occurred. So I think that's where I recommend sort of that serial every 6 months sort of pelvic ultrasound on cloaca patients. But if we've made it through menarche, things are going fine, there's no issues, we don't need to keep repeating those ultrasounds. So don't want to keep your radiologist like office too busy, but just want to make sure that patients are safe and that we have not detected an obstructed system.
Great,
This has
thank
been
you
a
so
great
much.
experience for me. Thank you so much for the invitation, and we're hoping that the participants had a lot to learn today, and perhaps we can have a subsequent session about some of the older patients and how we might manage them.
Yes, definitely. We can stay in touch to organize another webinar, because this was great. Thank you so much. I would like to thank everyone that joined this webinar this evening, and also, of course, a big thank you to you two, the presenters, for presenting. This was very interesting. It was delightful working with you. I would like to mention that the webinar has been recorded, and I will be sending the links tomorrow to everyone that had registered for the webinar. You can find past webinars on our website and on our YouTube channel, so you can subscribe to our YouTube channel, and if you're interested in all of the webinars that we have organized in the past. Finally, all of you who have attended today will receive a survey immediately after the session has finished. So if you could fill that in, it will only take a couple of minutes. That way we can continuously improve further sessions, and you will also get an EACME certificate if you fill it in within 2 weeks' time. Yeah, that was everything I wanted to say. So thanks again, and have a good evening, everybody. And you a good day, Lesley.
Thank you.
Bye.